surgical treatment. So let's talk a little bit about why a transplant would be done. First, let me just go back a little bit and explain again, not the paradigm, but the actual treatment. So a patient with multiple myeloma, if they were coming to transplant, the first step would be to confirm the diagnosis, measure the disease, etc., etc. Make sure that this is the best thing for them and for their particular situation. The first step of the treatment is to acquire those seeds, like the new grass that we would be using to replant the lawn. You've got to make sure that you've got those seeds in hand, because if you didn't and you went ahead and destroyed your lawn and then had nothing to replant it with, you wouldn't be in a good place. So that first step of obtaining the cells with which you would replant the marrow is what we call mobilization, or we try to mobilize those cells, those seed cells, which are called stem cells, bone marrow stem cells. We try to mobilize them from the patient's marrow, collect them, and then they can be frozen in special refrigerators where they can stay frozen practically indefinitely. So that's step one. We try to obtain those stem cells, freeze them, and put them away. Then step two, which is where we would go to destroy the lawn which has gone bad, is the actual transplant chemotherapy. And we use chemotherapy. Nowadays, almost all programs use melphalan, which is probably still, even though it's a very old drug, one of the most effective single agents against myeloma cells. This is a very powerful drug. But giving melphalan in a high dose is able to destroy myeloma cells. Now, as a side effect, it's also going to destroy the normal grass, or the normal grass equivalent, which is the normal bone marrow. But following that, you are able to replant that, so you don't care. In fact, the more cells you can destroy, the better. So the patient then comes in. Over a 2-day period or 3-day period, you give them high-dose melphalan. Nowadays, a proportion of patients can get this treatment as an outpatient without having to stay in the hospital. Not everybody, but some. The third thing you would then do is you would go back for the cells that were frozen away in those special refrigerators, thaw them out, and reinfuse them into the patient. And they are reinfused by vein. It's not a surgical procedure. They don't have to get driven into the marrow. They are literally given by IV, by an IV method, through a special IV, a port or a catheter of some kind. And once that is done, those cells can themselves seek out the places in the bone marrow where they are supposed to go. And they then regerminate, and over a 2-week or so period would re-establish the bone marrow again. Now with a much, much smaller percentage of the bad cells or the weeds. Unfortunately, it's not able to take all of the bad cells out. So there is a likelihood of relapse at some point in the future. But what you do through this process is you take, by analogy, taking a lawn which has 50% weeds and 50% good grass. You change it to a lawn which now has 2% weeds and 98% good grass. The percentages are even higher when you actually count the bone marrow cells. So you find that you could take somebody who has 20% bone marrow myeloma cells and change the proportion so that after transplant, in the first transplant, you might not even be able to find myeloma cells. And the only reason we know they are still there is that with time, some of them begin to show up. So why transplant for myeloma? First, it's a one-time treatment. So many of the treatments for myeloma are ongoing or repeated treatments. When it used to be chemotherapy with VAD, every month you would go and get treatment all over again. Velcade, many of these treatments are treatments that are ongoing and so on. Transplant is a one-time treatment whose benefits last for several months or sometimes even a few years beyond the time of treatment. So it provides that effectiveness which gives you then some leeway. I always like to point out to patients when treating cancer that yes, you want to survive cancer, of course, that's the number one goal. You want to beat it, you want to outlive it. But not only that, there's a secondary goal, which is that you want to live even when you have cancer with as little disturbance to your normal lifestyle as you can afford. So if you can take a treatment which gives you a period of time where you can return to your normal lifestyle and do the things that you normally like to do, even if that treatment might not cure the disease, it's still a valid endpoint. We will still accept that as a part of the results of treatment. Secondly, these types of transplants are very safe. In clinical trials where they measured how many patients survive a transplant, and this is dating back 10 years ago, even at that time, fewer than 3% of patients would not survive the transplant process, and very often the reason for that might not even have to do with the transplant itself or the myeloma, but something else, but they were still counted in. So this is a treatment where in hundreds of patients now, thousands of patients have been treated now. The percentage of patients who actually survive the transplant is very close to 100%. That's not to say 100% of patients are cured or even necessarily benefit, but at least it's a treatment that we can say with almost 100% certainty that the patient who has been felt to be eligible after screening will likely be able to get through the treatment without permanent side effects or without major losses. It prolongs life expectation, so we can all play the statistical game. When someone is first diagnosed, it's easy to go to a textbook or a clinical trial or something like that and look up and say, it's just like the insurance tables when you're going to buy life insurance. So recently I had reason to buy life insurance again, and they come and meet you and they look at my balding head and my gray hairs and my blood pressure, and they say, well, you are expected to live so and so, and so we will only sell you this amount of insurance for that amount. And we can do the same with practically anyone, even individuals who do not have a diagnosis like multiple myeloma. You can look up anybody's statistic expectation, but all of us know that that is merely a statistic. And I'm always very hesitant to say to any one patient, except for the purposes of planning, just like when we buy life insurance, we are really just planning for possibilities. And we can do the same with myeloma, but you can look up these numbers. And when these numbers were looked up and compared between patients getting a transplant and those who did not get a transplant, it was clear that a transplant early in the process of multiple myeloma added time to the average expectation. Now, there are some patients in the transplant group who might not do as well, and some patients in the non-transplant group who might do better. But on average, transplant added some time. And then there was this measurement of something they called time without symptoms or treatment. So this refers to the duration of time between a transplant when the symptoms might go away or the symptoms might improve until the next time that somebody would need myeloma-specific treatment or might develop a side effect which was due to myeloma. And this time was also prolonged in patients who got transplants. So if for someone